Welcome to the Gyne Awareness Podcast, real talk to understanding gynecologic conditions and care. The goal of this podcast is to bring you clear, evidence-based medical information by experts in the field of gynecology to help empower you in your health journey. Participants on this podcast are healthcare professionals, specialists and advocates in the field of minimally invasive gynecologic surgery. The views and opinions shared in this podcast are those of the speakers and do not necessarily reflect the official policy of AAGL. This content is provided for general educational purposes only and is not a substitute for professional medical advice, diagnosis, or treatment. Listeners should always seek the guidance of a qualified healthcare provider with any questions about their own health. If you are experiencing a medical emergency, call 911 or your local emergency number immediately.
Hello there. My name is Dr. Angela Chaudhari, and I'm a gynecologic surgeon and professor at Northwestern University Feinberg School of Medicine in Chicago, Illinois. I will be your host today for the AAGL Gyne Awareness Podcast, a podcast designed for our patients to empower them in their health journeys. We are bringing you experts in the field to hear the real truth about conditions that impact so many people. Today, we will be discussing endometriosis, and I have an amazing panel of physicians joining me today to give you all the information that you need. First, Dr. Shanti Mohling is a minimally invasive gynecologic surgeon at Northwest Endometriosis and Pelvic Surgery in Portland, Oregon, with a clinical focus on all things pelvic pain. Dr. Sony Singh is a professor and chairman in the Department of Obstetrics and Gynecology at the University of Ottawa, as well as research chair in gynecologic surgery in Ottawa, Canada. And finally, Dr. Cara is section head of minimally invasive gynecologic surgery and medical gynecology, as well as the director of innovation at the Cleveland Clinic in Cleveland, Ohio. Welcome, and thank you so much for being on the Gyne Awareness Podcast today. Let's get started, everyone. So endometriosis is such a common condition that's currently plastered all over social media. Everyone's talking about it. Everyone thinks they have it. So let's talk about it. What is endometriosis? Dr. King, do you want to start us off?
I would love to start us off. Thank you so much for having us. This is, like you said, such an important topic. So endometriosis, what is it? So endo is when tissue similar to the lining of the uterus gets outside of the uterus and can implant anywhere. So it can be in the pelvis or the upper abdomen. It can be on the surface of the ovaries. There can be ovarian cysts within the ovaries. It can be on the peritoneal sidewalls, on the bowel, on the bladder, on the appendix, and even in the upper abdomen on the diaphragm.
Well, and I know my patients are going to ask, how in the world does it get there?
Do you want me to take that?
Let's do
That's
it.
a hot topic.
You got it.
Great question. You know, I wish I could say there was one way that it got there, right? But there's multiple different theories. And the reality is that there's probably no one way. There's probably multiple ways that endometriosis can get there. So one theory that a lot of us have heard about before is probably retrograde menstruation, which is when you can have period blood go backwards through the tubes and land in the pelvis. So this may be one way, but I will say that most likely most women have some element of retrograde menstruation, and only about 10%, I shouldn't say only, 10% of people with uteri have endometriosis. So there must be other ways that endometriosis can start and can grow. Sony, do you want to take away some of the other ways that endo can form?
Yeah, and I think, first of all, thank you so much for organizing this. And it is so important to talk about the ways in which endometriosis grows or occurs because we need to do research. And so our research program is looking at a couple of different things. We're looking at the fact that the immune system can't really get rid of this tissue, which normally doesn't belong there. Why is that? The inflammation that is then caused to cause all the damage to the tissue in other areas as well. You know, again, it is important to recognize that endometriosis is not a cancer per se, but it does travel similar to a cancer. So we've actually seen genes, especially in something called deep endometriosis, which is one of the more severe forms, that are similar to some types of malignancy or cancer as well. So again, it is important. It's not a cancer. However, some of the mechanisms, when we understand it better, we might be able to actually target treatment better as well. So back to Cara saying that there's many different causes, but we're going to try to figure out over the next few years, decades, how to get to the real solution and the real cause.
So obviously, we don't really know the cause. That's what I'm hearing from you guys. We've got a lot of research out there figuring that out. So what do we think, the common symptoms of endometriosis are? And Dr. Mohling, I know you have a real focus in all things pelvic pain. Can you share with us what your patients kind of tell you?
Absolutely. I think we start with this like classic triad that people describe, which will be dyschezia, so painful bowel movements. Dyspareunia is a fancy word for pain with intercourse or pain with sex or pain with orgasm. And also, of course, dysmenorrhea, which means really painful periods. So the three dys's, but people can also have painful bladder. They can have chest pain. It can be on the diaphragm. It can be even above the diaphragm into the lung. They can develop pneumothorax that comes with the period. They can have it so invasive that it goes into the bowel, and they might have bleeding when they have a bowel movement. So endometriosis is not just like simply a small deal with some cells outside, and it is actually something so aggressive at times, and sometimes just inside the lining and not as aggressive, but still causing significant pain. So I think that sometimes we even hear from patients who say they get headaches associated with their endometriosis, or they have extreme fatigue or depression. And we know that all of these things are associated, not just the things that are obviously associated with the organs.
Yeah, it sounds like it touches literally every organ system the way you're describing it, right? And so if we have patients out there listening who say, I just have painful periods, maybe my painful periods are just that, right? They're not really, I don't have all those other symptoms. What should a patient who has painful periods be asking their doctor? Sony, you want to take this one away?
Sure. I think first and foremost, I think about my own daughter. I think about my family. When I think about patients who come in, what would I want for my own family? And that's what I would want my patients to do, is advocate for themselves, be able to communicate that they are struggling. Pain with your periods is something that we can help with. And somebody who's been suffering for years, if it's not treated, can develop then chronic pain. And that's really tough to manage. So what I talk to my own daughter about a lot is the fact that we want to encourage young girls and women to speak up and advocate and ask the questions. Why is this happening? How can I get help? And unfortunately, access to care is a big problem. We don't actually have enough recognition, despite talking about this all over social media and other places. We still don't have a grasp in society about the issues around menstrual pain or menstrual health or hygiene. And so it is important. I would leave you with just, the advocacy component is probably the most important thing. Speak up for yourself and, really go out there and try to do the best you can do to advocate for your own health.
Yeah, that's amazing. I mean, I think advocacy is the number one thing we're trying to get across here. More people should know about this disease and be able to advocate for themselves, such that really they are doing the best thing for their own health journey. So if a patient comes in to see any of you, how might you go about diagnosing them with endometriosis? What's really like the things that you're looking for?
I want to, if you don't mind, I want to jump to Sony really quick with him talking about the kiddos, right? Like the adolescent age people who are having pain, and like what is normal, what is abnormal. I hear this a lot, right? Like, well, I don't hear I have that many symptoms. Maybe I'm okay. I want to just reiterate that if you're having periods and you're not doing the things that you want to be doing during your periods, right? Like if you're not going to school on those days, you can't go to work on those days, that is not normal. Like you should be able to function during your period. And if you can't, that is not normal. And for parents who are listening, if your kiddo is going to the school nurse during their period, if your kiddo doesn't want to go to school on those days, take notice of that. And, we talk about being an advocate for yourself. And I want to apologize now to our patients that have been having to advocate so hard for themselves, right? And I think educating other healthcare providers within OB/GYN, but also emergency room docs and primary care docs, we're working on that. Because I always just think about my patients who have already suffered for 7 to 10 years, right? Delay in diagnosis, and then asking them to advocate even harder for themselves. I just want to apologize now that we are working on closing that delay.
Well said.
Thank you. Thank you. But to your question of how do we diagnose patients, I think first and foremost, we listen to our patients. I will tell you this now, you know your body better than anybody else. And so when you see a provider, again, whether it be an OBGYN or a primary care doc or an emergency room doc, trust yourself and that your symptoms are real. And so first and foremost, we listen to your story and we believe you. And from there, we ask all the questions that a lot of us are talking about now. So pain symptoms, what is that pain around? Meaning, do you have pain when you urinate, or when you have bowel movements, or when you have intercourse? We talk about other lifestyle things that may be also impacted. So difficulty sleeping, difficulty eating. We tap into all the different avenues of your journey and of your story. So first and foremost, listening and getting a really good history.
Perfect. And then I'll just take it from there. I'm certain you do the same thing, is once you've gotten this history, and that might include also family history. Do they have family members who have this disease? Did they have their mother had a hysterectomy at age 30 because of terrible pain? These kinds of things will impact a diagnosis or my feeling that someone has a likelihood of endometriosis. But following your full history, a really careful exam. And so many patients have had an exam that was just like, okay, there's your cervix and uterus, and yes, it hurts like that. Okay, but everything's normal. And in fact, if you really carefully do an exam, you can find that there are specific places that hurt more than other places. And sometimes you can feel little nodules behind the cervix, or you might feel a thickness. I often do a rectal exam. Actually, I always do a rectal exam on a patient if they are willing, because you get so much information. Sometimes you find that between the rectum and the vagina, it can be filled with disease. And when you encounter pain, when you're doing that part of the exam, it's really a clue that there may be more disease. And then, do the structures move? Can you move things easily? Yes, okay, good. Maybe not a frozen pelvis with massive disease, but that doesn't mean you don't have disease. And then we go to imaging. How about I toss it to you now, Sony?
Yeah, the imaging story is incredible. So first and foremost, I've known all of you for many, many years, and I think that one thing that definitely resonates is how well you listen to patients, and I hope I do the same. And go along that journey with the patient, those years of struggle, because it takes years to see us sometimes. And I think that part of the journey and that part of that therapeutic relationship is essential. And listening to the patient and then examining them. But then comes imaging. First and foremost, I don't want to put all of our eggs in one basket to say that imaging is always going to make that diagnosis. I think there's a lot of confusion there. However, we've come so far with imaging. We now can see deep endometriosis. In fact, we could always see it. We just didn't know what we were looking at. So in our center, we have a program where we actually are able to look for what we call soft signs. So markers like the exam that suggest that somebody might have endometriosis. Then we do a more detailed exam prior to surgery that can really map out the level of disease. There's MRI as well. But again, with all of these things, just like with the clinicians that we talked about, we need people who are knowledgeable and skilled to be able to get these answers. So history, examination, imaging all together, but it really makes a difference that we have people who do this all the time and focus on it. And that's something I wouldn't have said 15 years ago because I was younger and, wanted to make sure I was a bit more kind. We're a Canadian. But to be honest, with endometriosis, it's just like other severe complex conditions. The more expertise, the more likely we're to diagnose. But we help our primary care providers and our gynecologists who do more primary care. We help them by educating them on who to identify so that they can then send them for more advanced diagnosis.
And I want to add to that. I think that so many of our patients are in places where the imaging professionals, let's say, don't have the skill set to identify endometriosis, and particularly when it's subtle. They might be able to say, yeah, this is a big uterus with adenomyosis, something kind of similar, or they might be able to say, oh, there's an endometriosis in a cyst, that's an endometrioma, and that can easily be seen on ultrasound. But a lot of the times you as a patient may have ultrasound after ultrasound being normal, and yet it turns out you have really significant disease. So I want to remind everyone that even if you have negative imaging, it does not rule out endometriosis. And when we say negative imaging, it means imaging that looks normal. So normal ultrasound doesn't mean you don't have endometriosis. It just might not be in the right hands, or it might be maybe stage 1 disease that still hurts a lot, but doesn't show up on most routine scans.
And for our patients listening who don't have the experts like you in their town or in their communities, right? My question really for you is, what should they be saying to the doctors that they do have, whether that's a primary care doctor or a family practice doctor or a general gynecologist? If they are suffering, what should they be asking for?
That is a great question. And I wish we had like the exact right answer for that. So I would say, again, trusting your symptoms. And sometimes if you go to somebody who doesn't do this all day, every day, they don't know what they don't know. So I'm going to say that. Everyone's doing the best that they can within their ability. Not that that makes it right, but some people don't know what they don't know. So number one, trust your symptoms. Two, I think it can be really helpful to keep a pain journal or a pain log, right? So you can just understand timing of your pain, severity of your pain. When is it better? When is it worse? In the morning, in the afternoon, with periods or not, all the different details. And I think that can also help translate to your provider who you're speaking with the severity of the disease that you have. So I think that can be really important. And then understanding that endometriosis is part of the differential and bringing that up to your provider. So bringing up that endometriosis is a concern for you and being confident enough to verbalize that. And I think if you feel like you're not being listened to or they're not taking your concern seriously, finding somebody else. So on our AAGL page, we have a list of providers who are specialized within endometriosis. And I think looking on the AAGL website and finding that list of providers can be very helpful at finding the right person and the right fit for you. What do you guys think? What am I missing?
Well, I think you're right on, Cara. I think at the end of the day, I did like what you started with, which is the basic assumption I have is that everybody is trying to do the best with the information and the education they had to that point. So, when I went through, we didn't have any of this. Endometriosis was this rare condition, and we'd be surprised every time we did any surgery. So we've come a long way. And so I really want to acknowledge that not everybody has gotten that training. So a couple of great things that we're doing at our own center, but many of you are involved in, is we're educating others regularly. So we have a project right now with our fertility group to teach fertility centers to use simple signs on ultrasound to help early diagnosis of endometriosis, because most of the fertility centers who have been around for a long time weren't taught about how to detect this type of disease. At the same time, teaching in medical school, starting medical curriculums, and also residents and fellows. We do a workshop twice a year on endometriosis. And so I think all of that will make a difference when we start to get the word out. And so when a patient comes to someone, I think, again, bringing it up and a good therapeutic relationship, that provider says, I didn't know that. How can I help you? And I think that is something we need people to know.
And I want to add that so often patients come to, I'm sure the two of you and to myself, and they've been to doctors over and over and over for years, and they aren't heard. And so I want to almost re-emphasize what you were saying, Cara, about keeping a journal about all those symptoms and recognizing that those are all really important. And so many patients have a diagnosis of irritable bowel syndrome when in fact it turns out they have endometriosis. So including all your symptoms, what doesn't feel right, and trusting that you don't feel your situation is normal, and you're staying home from school or you're staying home from work, and really recognizing that that should not be normalized, right? You shouldn't have to drink a whole bottle of ibuprofen just to be able to go to work.
Shanti, you said something there that I'd love for you to expand upon, is really like what other things could this be, right? Everyone has these pain symptoms. They hear endometriosis, they know it, they're kind of scared of it, to be perfectly honest. But there are other things that cause pain. And I know you see patients with all sorts of pelvic pain. I'd love for you to sort of share for patients what else they might have.
Yeah, and that's that's such a good point, because we think endo, and we really need to always take a step back and remember that there are other things that can cause pain. So, other kinds of ovarian cysts, like a dermoid cyst growing large, can cause some pain. Chronic bladder inflammation, we call interstitial cystitis, that can cause chronic pain. Truly irritable bowel syndrome or other ulcerative diseases of the bowel can also cause pain. Peritonitis can cause acute pain, but not usually chronic, ongoing, cyclic pain. And then we do see some people who have terrible myofascial pain, so musculoskeletal pain. And very rarely I'll do a laparoscopy and look in someone, maybe 2% of the time, and they actually won't have endo because I've screened them well. But that's when you have to begin to really think out of the box. Was it myofascial? Do they need trigger point injections? Do they have a bladder issue going on that we really need to sort through? And do they have neuropathic pain? Do they have nerve impingement somewhere that we need to address? The list goes on, I think.
Yeah. So I love this, Shanti. I think if I can add, so I had to teach it, I had to learn myself all about chronic pelvic pain because no one taught me about this. So when I started my practice, I was taught how to cut out endometriosis very well. What I wasn't taught about was pain, because I think, 20 years ago, it was not really recognized that chronic pelvic pain is a thing. So to add to Shanti's part, I love the idea that I look at a patient holistically, like all of you do. And some of the other areas that I've worked on is diagnosing all the orthopedic issues. So hip issues, when a patient comes in and says it's my ovary, especially when they've had it removed by somebody else and they still have pain and other things, they've actually got what we call a labral tear. They may actually have other conditions. I have a significant number of patients with something that I thought was rare called Ehlers-Danlos syndrome, which is a connective tissue disorder. There's other whole body issues that we need to work with and understand. So, I know this is tough because there's only so much you can do in your life, in your practice, but I've really enjoyed working with my patients to unravel sometimes the mystery that is behind the pain. And it's okay to also understand that endometriosis could have been the start of all this, or the pain generator, but you're still human. You may have 3 or 4 other things as well. So once you take care of the endometriosis and Dr. Mohling's done your surgery, doesn't mean that you still don't have other issues. So what I tell patients, it's a lifelong relationship. And, sometimes it's a roller coaster. It goes really well, but then you might have a down day, you might come back up. And we're going to work with you for a lifelong plan.
Oh my gosh. All the patients are going to be trying to get into the 3 of you. I'm just letting you know. I mean, I think really what I took from this whole discussion about endometriosis diagnosis is like, we as doctors who treat patients like you who are listening, who have pelvic pain, who have dysmenorrhea, we hear you and we believe you. We know you have pain. And even though it feels like you've gone from doctor to doctor and not everybody listens, oftentimes it's not because they don't want to listen. It's because they just don't have the education or the tools to treat you best. And so keep looking. And just like Dr. King said, we apologize that you have to do that. But I'm so excited to be on with this panel to really share all this information with you.
Thank you for listening today. We hope you enjoyed this podcast. To listen to other podcast sessions, visit us at gynawareness.com. You can also follow or subscribe to the Gynawareness podcast on Spotify or Apple Music.